Hello, and welcome to this session on managing symptoms during benzodiazepine tapering. My name is Amy VandenBerg. I'm a board-certified psychiatric pharmacist with over 20 years of specialized practice managing medications used to treat psychiatric and neurologic conditions, as well as substance use disorders. I served as one of the members of the ASAM Clinical Guideline Committee in developing the Joint Clinical Practice Guideline on benzodiazepine tapering, and today I'll talk about how to manage symptoms during the taper process. While benzodiazepines were first FDA approved in the 1950s, they remain a therapeutic option for many conditions, ranging from anxiety and insomnia to various neurologic conditions. Currently, about 10% of U.S. adults have active prescriptions for benzodiazepines. And while for decades, treatment guidelines for anxiety and insomnia have considered benzodiazepines appropriate for short-term use on the order of weeks, many patients continue to take prescribed benzodiazepines chronically, sometimes for many years. When discussing risks and benefits of benzodiazepine tapering with patients, messaging is very important. The message that patients commonly hear, whether overtly spoken or not, is that benzodiazepines are bad, so they have to be stopped. Patients may respond better to a more nuanced discussion specific to their risks and benefits. These can vary from patient to patient and over time in individual patients. With younger patients, risks may include oversedation and risk of motor vehicle accidents, whereas falls and cognitive impairment become additional concerns in older adults. For patients at risk of substance use disorders, for example, with family or personal history of substance use disorder, potential for misuse and higher risk for overdose may also be a focus. Making sure to discuss risks specific to the patient can help with buy-in regarding tapers over time. I'll tell low-risk, younger adult patients the risks of use may actually be low now, but the longer you take this medication, the harder it will be to taper off, which will be the eventual goal. So let's start thinking about the next stage. For older patients, I discuss the risk of falls and cognitive impairment that may prompt more rapid discontinuation in the future and try to engage them in tapering slowly before those risks become more imminent. In all circumstances, I fully acknowledge that benzodiazepines can be rapidly effective for managing acute anxiety and insomnia, but also note that they may lose efficacy over time. The risks of slow tapering are most commonly recurrence of symptoms and mild withdrawal symptoms, whereas fast tapers increase the risk of more severe withdrawal symptoms and increase the risk of patients using non-prescribed benzodiazepines to manage symptoms. With slow tapers, in fact, it may be difficult to differentiate mild withdrawal from rebound symptoms, which may include increased anxiety, trouble sleeping, irritability, and restlessness. Risk of moderate to severe withdrawal increases with rapid tapers, large dose decreases, and abrupt discontinuation, and can progress from mild to serious in a matter of days. Rebound symptoms are more likely to plateau, whereas withdrawal symptoms may continue to increase if doses are decreased too rapidly. Patients should be monitored closely during tapers for increasing severity of symptoms, cognitive changes, and suicidality, and symptoms such as hypertension, altered mental status, and perceptual disturbances may indicate risk of progression to dangerous withdrawal, including delirium and seizures. Moderate to severe withdrawal symptoms should be managed with benzodiazepines and may warrant inpatient treatment. In addition to these, a small percentage of patients may experience protracted withdrawal even months to years after tapering or discontinuing benzodiazepines. This phenomenon may include anxiety, depression, perceptual disturbances, insomnia, and even motor disturbances. So it is important to monitor patients closely both during the taper but after the taper is continued. One thing to consider prior to initiating a taper is planning how chronic symptoms will be managed. For anxiety disorders, this may include starting antidepressants, most of which are effective for anxiety disorders such as generalized anxiety and panic disorder. Non-pharmacologic strategies ranging from cognitive behavioral therapy, if it is available and feasible for a patient, to exercise and relaxation technique can be used alone or with medications. Alternatives may take weeks to months for full benefit, so whenever possible, they should be initiated at least 1 to 2 months prior to starting a taper if it is safe for the patient to delay the first dose decrease. It may also be reasonable to offer alternative as-needed medications for breakthrough anxiety either prior to the taper or during the taper. Patients should be informed that alternatives like hydroxyzine will not have the same effect as benzodiazepines. Rather than taking anxiety, say, from a 10 to a 2, hydroxyzine may decrease symptom severity from a 10 to a 6. And while this is still a 40% symptom decrease, it's not going to feel the same. I tell patients that using multiple strategies such as antidepressants and CBT and exercise, for example, may drive overall anxiety down to that desired level of about a 2. And patients can be reassured that chronic management with these strategies may be more effective in the long term compared to benzodiazepines, even though it may take a while to get to that point. Gabapentin is another option to use during the taper process, which may take the edge off of rebound anxiety or mild withdrawal symptoms. My analogy for patients is that while benzodiazepines are like pushing on the brake on your car, gabapentin is more like taking your foot off the gas. So it still slows down anxiety, just not quite the same way that benzodiazepines do. Strategies can be implemented for insomnia as well, ranging from cognitive behavioral therapy specific for insomnia, again, if it's available for patients, to sleep hygiene, and we can also use alternative medications like doxepin or trazodone. In addition to managing anxiety and insomnia, it's important to consider other underlying conditions like depression and pain that may drive anxiety and insomnia and optimize treatment for those as well. So who's at risk for withdrawal? Well, all patients will develop some degree of physical dependence as early as 2 to 4 weeks into chronic benzodiazepine use. While there's no specific formula, risk of benzodiazepine withdrawal increases with increasing duration and quantity of use. But some patients may experience withdrawal even after relatively low doses and relatively short courses of treatment. And some patients on longer treatment with higher doses may experience minimal withdrawal. So there's going to be variability between individual patients. All benzodiazepines carry the risk for withdrawal, while some sources indicate or recommend switching to longer-acting agents like clonazepam or diazepam for tapering, and there are estimates for approximate dose equivalents between agents. Not all patients will benefit from conversion to a longer-acting agent. Conversion tables may be used as a guide, but recognize that some patients may require higher or lower doses than tables recommend based on individual factors like rate of metabolism and interactions with other medications. So while it may be appealing to switch to longer-acting agents and dose them less frequently, it's not always the best option. There are limited validated tools to specifically assess benzodiazepine withdrawal symptoms. The CIWA, or Clinical Institute Withdrawal Assessment, that was originally designed as a 10-item scale to assess acute alcohol withdrawal, was adapted to a 22-item scale to assess acute benzodiazepine withdrawal, but it has limited sensitivity and specificity. It's more relevant in the setting of rapid tapers that may occasionally be necessary in the hospital setting. And the other rating scales may be used at baseline and throughout the tapering process to assess other symptoms like suicidality, insomnia, and anxiety. So these would be the Columbia Suicide Severity Rating Scale, PHQ-9, Insomnia Severity Index. What may be easiest in practice, though, is something like the Clinical Global Impression, which is a 7-point Likert scale assessing either severity of symptoms or level of improvement. This has been validated against many specific rating scales for anxiety, depression, and insomnia. And with slow tapers, I encourage patients to self-rate their symptoms on a scale of 1 to 10, generally assessing for rebound anxiety and insomnia, rather than monitoring themselves for more moderate to severe symptoms. But once a plan is in place to initiate the taper, other symptom management strategies have been implemented. Considering the first dose reduction is crucial. Many patients on chronic benzodiazepines have been tapered quickly in the past, often with a 25% or more dose reduction every 1 to 2 weeks, and had significant withdrawal symptoms or symptom recurrence. Some patients even view these previous rapid tapers as punitive, and they may be fearful of large dose reductions and discomfort again when they hear the term taper. Reassuring them that this will be a slow taper with small dose decreases can be helpful. The first dose reduction of only 5% of the total daily dose can maximize tolerability and improve patient comfort with further dose decreases. Now, obviously, it's not possible for a patient to take 95% of a tablet, so this can require some creativity. For example, if patients are taking 1 milligram of lorazepam as a 1 milligram tablet twice daily, we may prescribe 0.5 milligram tablets and have them start with 2 tablets for a 1 milligram dose twice daily, and then have them cut one of those 0.5 milligram tablets, even in quarters, and remove a quarter of one of the 0.5 milligram tablets once a day, and while still taking a full milligram dose for their second dose. So these are very small dose decreases. Some patients may benefit from even having a dose decrease only once or twice in the first week, so there's only a few days where they take a decreased dose. Others may benefit from having a set taper where they take the same amount every day. So there's going to be some variability in what patients prefer and what they can manage. If symptoms recur with a dose reduction, it's best to maintain that dose prior to the next dose reduction rather than increase back. But if symptoms increase in severity, especially if it's a larger than usual dose reduction, it may be necessary to return to the previous dose. A good rule of thumb is that the longer a patient has been taking benzodiazepines, the longer the taper will take to be successful and well tolerated. And this may mean 12 months or longer for tapering benzodiazepines, especially in patients with chronic use. Finally, there are a few other things to consider when tapering. First is the contribution of other substances, both in risk-benefit assessment and in the success of the taper. Concurrent use of stimulants may be activating for some patients and may worsen anxiety. So considering the balance of, say, anxiety and ADHD symptoms can be important. Cannabis can increase anxiety in some patients. And it's also important to let patients know that cannabis, even if it seems anxiolytic or decreases anxiety with acute use, can increase chronic anxiety over time. Additionally, if patients are trying to taper off of opioids or they are in the midst of discontinuing alcohol, these symptoms of alcohol withdrawal, opioid withdrawal can overlap with benzodiazepine withdrawal. Optimizing one taper at a time can be beneficial. The other issue is timing. So once a taper plan is discussed, if it's safe to wait, looking at the next 3 to 4 months for a time that's best for the patient can help with success. If a patient has major life events anticipated in the next few months, it may be best to either wait or start with the smallest feasible dose reduction and longer intervals between dose reductions. You can also work with patients to identify modifiable stressors that may help them with decreasing stress overall and reiterate the benefit of non-pharmacologic interventions, encouraging the patients to identify a few activities that may decrease anxiety and insomnia other than medication to see if we can get symptoms controlled again through some of those non-pharmacologic measures. So to wrap up, benzodiazepines are effective medications with patient-specific risks and benefits that change with age. Many patients are afraid to stop taking benzodiazepines, both because of the rapid improvement they see with each dose and previous negative experiences with tapers or missed doses. Early signs of withdrawal and signs of symptom recurrence significantly overlap, but both can be distressing for patients. To mitigate these symptoms, alternative management strategies, either pharmacologic or non-pharmacologic, should be implemented before slowly tapering. Thank you for watching. I hope you found this helpful. For more information on tapering benzodiazepines, please explore ASAM's additional micro-learning videos and webinars available on the ASAM e-learning center. And please visit the full ASAM benzodiazepine tapering guideline for further details.